All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So this study from Switzerland, I had incorrectly written Sweden, my apologies. This study from Switzerland, Basel University and Department of Cardiology and the Cardiology Research Institute of Basel University and the University Hospital, it's a tremendous study. The participants who received booster vaccine for the first time, 777 hospital employees, they observed the evidence of myocarditis or cardiac cell injury on the third day in 2.8% of them. Women were 3.6%, men were 0.8%. And this is compared to 0.0035% originally published number of cardiac injuries after the vaccine second dose. Although this comparison of about 800 times difference, you would see during my talk that this comparison isn't exactly correct comparison. So we'll see why not. But this is a very high number, and this is a concerning number. And this particular study goes back to somewhere in 2021 January. I did a talk about the clotting disorders because of the vaccines. There was a German study that came out and that talked about Oxford AstraZeneca's or adenovirus-based vaccines clotting propensity, especially for women. And I remember there was just so much hatred and angry messages. And I was saying that if we are aware that this is happening, then we can be ready for when it happens and not allow a lot of damage. Similarly, when we talked about cardiac issues as well with the vaccines, my point has been that we should know so that we can help the patients. This is the first time I'm seeing a study where one part of their conclusion is to say, make sure that you are aware that this can happen, and so that you can make sure that your patient, the person who received the vaccine, they are not stressing too much, they're not exercising too much, or they're not risking themselves too much. And they say in the study that we do not know the long-term effects. We do not know if the arrhythmias will develop in these patients or not, patients or persons, or cardiac failure would develop or not. They do say that we think that the outcome will be favorable, that they don't suspect that permanent damage would occur. But ignoring this will be wrong. And I think about it for a second while I go through the study. If a booster dose can cause myocarditis or cardiac cell injury in some patients, what if they continue to take boosters, being a good citizen of the world, they continue to protect themselves and others by taking the boosters? What will happen with continuous repeated insult to the cardiac tissue? Will that accumulate? Or that is okay that they continue to recover? Just like if I get an injury on my finger, it's okay, it will recover, then I get it again, it will recover. But I have 10 injuries, we only have one heart. I have 10 fingers. So then we know that there is a plan to make more drugs and more vaccines on mRNA platform. If this is a possible outcome and more frequent outcome, then we might actually expose our generations, new generations and old equally, to a long-term effect that we don't understand yet. So that is really concerning. Let's look at the study first and look at various points of the study, and then we'll discuss more if we need to. So these are the gifts of humanity, and they are continuing. Here is the quick references to, I always get confused with Mac's keyboard attached to Windows. So here are the references. First of all, this is drbean.com, and we have tremendous amount of lectures over here. If you go to library, you will see lectures after lectures after lectures. And I would really recommend, if you're not a medical professional or student, then at least make sure that you have watched Chronic Inflammation, this series. And if you're a medical student, nursing student, NP, PA, or a doctor, then start from cardiovascular and then go from there. I have done so. We had changed the prices, and um, there were requests to make sure that that 67 is available for some more days. So just for this weekend, this 67 is available. We'll change it back to 97 after the weekend, just for this particular weekend. Okay, so here is the study. Sex-specific differences in myocardial injury incidence after COVID-19 mRNA 1273 booster vaccination. Interestingly, their point of view is not to talk about what is the incidence and why it is higher. Their points are that for the first time ever, they are seeing that females, women, are developing a higher incidence or have a higher incidence of myocarditis associated with the vaccine compared to men. And that is actually a surprise, because we thought that, or from the previous studies, we know that adenovirus-based vaccines cause more damage with higher incidence rate in women for clotting. And we always thought and read and taught that the mRNA vaccine was the cardiac incidence was higher in younger males or boys. This is a study that shows that men in the study had the incidence rate of 0.8%, women had 3.6%. And I saw somebody's criticism that the men in the study were less. That is true. So out of 777, 69.5% were women. But the numbers are still in percentages, and the numbers are good enough that the men should be in the same ballpark. And this is a difference that we are seeing. So this is the study. Here is the PDF of the study. I have the PDF here separately as well, which is marked. So that is here. Now going back, I have to learn how to do the tab switches with the Mac keyboard. And then there are some more links in here. One is this: what is the myocarditis after COVID-19 vaccine? Then this is COVID-19 and myocarditis, a systemic review. The incidence of myocarditis and pericarditis in post-COVID-19 vaccinated patients. Yale study of myocarditis, temporary mild damage to heart. And then we would talk about the interleukins, and we're going to talk about interferon lambda. So these are the references that are present. I'm going to just close these and go to the study with my drawings. So these are gifts for humanity. They're continuing. 800 times more incidence of myocardial injury than previously reported for hospitalized cases. So I specifically put that sentence in here for hospitalized cases, and that is the first difference. Although we can use the 800 times more, but the previously reported myocarditis numbers are for the patients who actually reported in a clinic or a hospital and got counted there because they had symptoms, and they went there and they got diagnosed with myocarditis. So I would consider that to be a more serious clinical and serious side. This study actually looked at people regardless of their symptoms. Actually, all those who developed myocarditis in here didn't have symptoms, and they didn't have EKG changes. They had the high sensitivity cardiac troponin. That is what was raised, meaning there was evidence in the blood of proteins spilling from the damaged cardiac tissue, from within the cell spilling outside, and that is what they were looking at. So this comparison, because of that, isn't really a fair comparison. So we'll talk more about that. I want to give you the summary of this talk first, and then we would go in some detail. Summary is this: first prospective study for the first booster, and specifically for the numbers in women, evidence of myocardial injury was 2.8%. So this is 1 in 35 vaccinees. This is a very high number because previously we've been talking about, for example, 1 in 100,000. And here we're talking about 1 in 35. So 2.8%. Compared to previously reported, which was in terms of percentages, 0.0035%. Now, as I said, 800 times more from the hospitalized patients. All cases were mild and transient. This is important to note because I see a lot of folks who are just pushing this as something really damaging to the patients. No, these are mild cases and transient. But the question is, what is the long-term effect? At the end of this discussion, after presenting the study, I would discuss that how inflammation of the heart can lead to arrhythmias and can lead to cardiac failure or the tissue damage. So there is a possibility of the tissue damage. So what will happen to these individuals down the road, and if they take more boosters, what would happen to them is not known. So no EKG changes were observed for 30 days. Women had a higher incidence, 3.7% versus men, 0.8%. Now, it is interesting that we have been talking about the mechanism of cardiac damage for a long time, and there have been many studies. The various etiologies or various pathophysiologies, we've been talking about them as the phenotypes of cardiac damage. And there have been studies or speculations or proposal of the mechanism, for example, inflammatory mediators becoming high in blood and circulating everywhere. So let's say I got the vaccine in my deltoid, it went to the local lymph nodes, the immune system became reactive, and inflammatory mediators are produced by these cells, and they're everywhere in the body, including the heart. And over there, they are now reacting with the immune cells that are sitting in the heart, and they're activating them, and those immune cells are now causing damage to the heart. That is one possibility. Another possibility is that, for example, there are antibodies against the vaccine that cross-react with the cardiac tissue, especially the muscle tissue, and go and attack that. Even pericarditis, meaning the layer of the heart, and they go and attack that. That is a possibility. Another possibility is the anti-idiotypical antibodies, that antibodies against the spike protein antibody. So when the spike protein is present, there is an antibody against the spike protein, then there are still another set of antibodies against these antibodies, and they are mirrors of the spike protein, and they go and attack the heart. I have done those discussions in the past. These researchers say that we don't really know what is going on. So they looked at various possibilities. They looked at the systemic inflammation. They didn't find any evidence. They looked at other possibilities as well, and they didn't find any evidence, especially anti-IL interleukin 1 receptor antagonist antibodies. And I will discuss that at the end. So I'm going to keep the mechanisms to the end so that we can see the study. And then if you have time, you can see what these mechanisms mean. They are also, it is a very interesting observation that all the patients, recipients of the vaccine booster, who also had evidence of cardiac injury, they all had two interesting molecules that were different. Number one, interferon lambda, that was less in them, all of them. Not all vaccinees, but those vaccinees that had cardiac outcome. And the cardiac outcome vaccinees, they had low GM-CSF or granulocyte monocyte colony stimulating factors, normally released by innate arm cells. These two were less. So the researcher said that we should figure out why these two are less and what is their role in the cardiac injury because the antibodies type phenotypes were not observed. So I want to read some parts of their manuscript before I go into the mechanisms. One over here, the long-term consequences of vaccine-related myocardial injury detected by transient and mostly mild high sensitivity cardiac troponin elevations on day 2 or 3 are unknown. Given the small extent of acute cardiomyocyte injury, cardiomyocyte is the heart muscle cell. Cardiomyocyte injury in our study, that is the CTNT, levels of about one-fourth of those observed in patients with spontaneous myopericarditis. So those patients who just generally develop spontaneously myopericarditis, compared to those patients, not because of vaccine, just for some other reason, the troponin levels here were about one-fourth. Then it was transient in nature as well, meaning those levels were not permanent. And they say because of this, good long-term outcome can be expected. So this is one. I wanted to make sure that this talk doesn't become a scary talk. Instead, at least see that the levels that they observed, they said these were not high enough to say there is going to be some permanent or long lasting damage, but they still said we are not sure what will happen in the longer term. COVID 19 associated with a substantially higher risk for myocarditis than mRNA vaccine, and myocarditis related to COVID 19 infection has shown a higher mortality related to than myocarditis related to vaccine. So here they're saying that the previous myocarditis that have been seen with the COVID infection have been higher in number and were more lethal. But then later on, they do clarify further as well that majority of the more lethal and more frequent myocarditis were in the early variant times. And they say in their manuscript that more recent variants and myocarditis because of these and any lethal outcomes because of these do not are not calculated. So we do not have the latest data, and that is a shame that countries have stopped looking at the Omicron or this more milder variants, hopefully less intense variants, impact on the body. And so we cannot compare this impact. We cannot say that today, what is the situation caused by this variant? We continue to look back from the original variants and the damage they did, and we keep reacting to that. So, as much as this is a statement over here, researchers further elaborate that. So then they say, thus, for the majority of individuals, the overall very favorable risk benefit ratio of booster immunization persists. However, further studies are needed to assess the impact of mRNA vaccine associated myocardial injury on the long term risk of cardiac arrhythmias and heart failure. So, again, at the end of this discussion, I would discuss that how inflammation of the heart can cause arrhythmias and heart failure. Then they say also evidence generated in the perioperative setting. Perioperative setting is before any hospital procedures. For example, somebody getting admitted to the hospital or discharged in the hospital. So perioperative, around the operation. Evidence generated in the perioperative setting should help avoid the oversimplistic assumption that the absence of typical chest pain on day 3 after vaccination in most cases would per se indicate a favorable prognosis. This is a very important statement in this whole study. I do not know that if other presenters have discussed this. What they are saying over here is that if there is myocarditis on day 3 and the clinical symptoms are absent and it is the patient doesn't even know and has myocarditis, they say that that may have, and they have a study here, study number 40, that has a less favorable prognosis compared to perioperative myocardial injury not associated with chest discomfort had comparable unfavorable long-term outcome versus perioperative myocardial injury with chest discomfort. That's very interesting. So one doesn't know that I have the issue, there are no symptoms, and the long-term effect of that may be worse than somebody who has cardiac issue and has symptoms. So, and they have marked that study. One can read that. Now, this is the summary of the study. This is the summary of the study. Now, the details. This study is for the mRNA 1273 booster, first booster, Switzerland, Basel. The number of vaccine receiving people, they were actually more than 777, but after the exclusion, they excluded anyone who may have had a reason for their troponins to be high, for example, a cardiac issue or a previous infection or a previous closely received booster. So they kind of excluded all those, and eventually 777 individuals, hospital employees who received this vaccine, and then there were another 777 who were control group. 69.5% were females. Median age was 37 years, so rather young. And third day from the booster, they collected their blood, and that is when they looked at that blood for about 14 inflammatory markers and the cardiac troponins and antibodies, anti interleukin 1 receptor antagonist antibodies. I still have to talk about that. Now, the question, I saw some folks commenting that this is a flawed study because they did not take the baseline of the troponin level. That is, before the vaccine, they did not take a baseline. So if you look at the limitations of this study and the discussion of the study, the researchers actually talk about it. And they say that when we got the approval for this study, there was a general consensus within the approval committee that we should not be spooking or scaring the people who are going for the vaccination by saying that we want to see what is your current status, and then we'll see what would happen afterwards. That would cause nervousness and people would just stop taking their vaccines. So they said we decided not to take a basal level, and then we decided to take the level at third day. Now, they also admit that if there is somebody who had troponin levels higher for longer time, they would not have considered them here, or they would not have been able to exclude them. But at the same time, troponin levels do not stay high for that long, and they do not stay high for that long without symptoms. So they had a very strict adjudication process with which they would figure out if this troponin level that is high, is that related or associated with the vaccine or something else? And because of that, there were actually 40 cases of myocarditis, and they adjudicated them and finally decided that only 22 of them met the criteria that these were vaccine associated and not for some other reason. So they had done a good job on that one. So they took their venous blood on the day 3 and did these markers: 1 antibody, 14 inflammatory markers, and the high sensitivity cardiac troponin. Now, I wanted to do a side note here. The comparison. So I'm seeing that comparisons, folks saying, hey, it is 800 times more, just like I said that as well. So 0.0035 versus 2.8, the difference is 800 times. Some saying 3,000 times and so on. So I want to make sure that we understand the KoolBeens here, that while these comparisons are kind of not accurate, here is why. Imagine that we have cardiac issue in a person, and there can be mild enough issue that there is, let's call that subclinical. That is, there is damage, there is an evidence of the damage, but there are no symptoms. Patient doesn't even know that it happened. So that is subclinical. Then there is damage with some symptoms that patient wasn't even concerned enough or were aware enough that went to the hospital. They just had some chest pain. They thought probably I have indigestion or something, and moved on. And then there is serious or more severe where they ended up in the hospital with the symptoms got diagnosed, had their EKG changes, had their MRIs or imaging done, and they found out that there is a cardiac issue. If you look at various studies in this context, this particular study looked at everyone who was not hospitalized. It was everyone who received the vaccine, regardless of if they developed any symptoms. And they say that none of them, all the people who developed cardiac evidence of cardiac injury in their blood, none of them had any symptoms even up till 30 days. So this, I would consider this to be a subclinical cardiac inflammation. This was not clinical. This didn't become serious. On the other hand, most of the other studies, other than the Israeli study and the Thailand study that I've discussed as well, most other studies are looking at the numbers of myocarditis for those patients who ended up in the hospital or got diagnosed because they had chest discomfort and they went to their clinics or doctors. That number is smaller. So comparing that smaller number to this number isn't actually fair. If in those studies as well they had done the subclinical analysis, they would probably find similar numbers. And that is why Thailand study, where they gave the injections, the vaccine to young boys, all boys, 15 years average age, I believe, and they then looked at their evidence of myocarditis and they saw a higher incidence. So because of that, comparing these two incidences isn't correct. But we should be able to combine them to say those who are receiving the boosters may be actually getting subclinical myocarditis and they don't even know. And some of them are becoming serious enough to go to the hospital, and here is that number. 0.0035 is that number, and 2.8 or 3.6 is that number for the subclinical. And there I have a problem with the healthcare authorities as well, that they should pick up these kind of studies instead of closing their eyes and or saying this is a rare situation or saying these studies are just stupid studies. They should pick up these studies and line them up and say, here is a study that said on a more severe side, this is the kind of outcome and this is the percentage of outcome. Rare or not rare, here is the outcome. And subclinical is this, and clinical is this, and more severe is this, and the lethal is this. And they should use these studies to chart the data and fill in these gaps. So comparison isn't the best. Then if we compare it to COVID, just like the researchers actually talked about it as well, and they said COVID had a higher frequency or greater incidence of cardiac outcomes and even more lethal cardiac outcomes compared to the vaccine related cardiac outcomes. But that was the previous variants. The current variants, I would request you to look at the manuscript. For the current variants, they say we do not have sufficient data to be able to compare them. So once again, comparing to COVID is also sort of not the correct number. So just like folks who do not like vaccines, they should not compare these. Similarly, folks who like vaccines, they should also not compare these because both numbers have a different, these represent different contexts and not comparable contexts. Yes, if we can do the following, if there is a study that looks at in the same age range, an age sex matched range, it looks at everyone who got COVID in this age range and then looks at their high sensitivity troponin levels, then that will be comparable. If you said that, hey, how about controls, general public, then this study has a control. They had 777 people who acted as control, and these numbers are compared to control. So that number is present, COVID, current COVID, and those numbers are yet not present. Okay, One more side note: what is the use of the study? What is it good for? So, first thing, this is something that I've been talking about for 2 years or more and getting lots of heat back. And that is, those who are getting vaccinated, including me, I got vaccinated as well. It is important for them to understand how to behave after the vaccine for some time so that they do not unnecessarily risk their tissues, their body too much. If the third day troponin levels are high, maybe they were high second day as well, maybe they were high fourth day too, maybe even after. It would actually depend upon everybody's response type. They only tested third day. Ideally, we should have a study that tests every day for 2, 3 months. So, barring that knowledge, if somebody has cardiac inflammation, for them to go out and exercise or to go out or stress themselves, uh, or do athletic activities or do young men, young women activities that they do is a risk. So they should be aware of it. And this is something that our healthcare authorities, instead of healthcare authorities closing their eyes and saying, well, bad study, they should take this data and create a guidance for doctors and patients. We cannot ignore these things in the name of vaccine hesitancy, that this would cause hesitancy. This is actually literacy. Having this knowledge and then using this knowledge is literacy. This is not hesitancy or not hesitancy. This is just the right thing to do. Anyway, so chill out after a booster. Don't exercise too much. Don't stress yourself too much. Keep an eye on the cardiac symptoms. So if somebody gotten a booster, went out partying, having fun, playing, hiking, and they feel any chest pains or discomforts, chill out. They should go back to their doctor. But don't put yourself in that state. Then care. This is for the physicians and the healthcare authorities. Care for the long term effect. What will happen in the long term? How can this inflammation be bad? Maybe it is not bad. Maybe this is like getting a small injury on the finger and then the finger got fully recovered. There is nothing that can happen as well. Then the researchers talk about it. They say maybe it is about the dose of the vaccine. They said maybe in women, the incidence is higher because their volume, overall tissue volume, is lesser than men. And their heart became affected because the heart's relative tissue volume is more for their own body. So heart received more blood supply and maybe that caused it. I think it is far-fetched, but that is one. The reason they did this thinking was to say maybe we should look at the vaccine dosage. I remember we used to talk about vaccine dose adjustment for various age groups and various people right in the beginning. So the researchers are talking about the vaccine dose. Then this is me, not them. Maybe we change the vaccine type. Maybe mRNA vaccine, sure, the whole planet is vaccinated with mRNA vaccine. Good. You achieved your goal. Maybe we do not have another pandemic. We do not have another serious situation. Maybe we go to a different mechanism, different vehicle for helping the immune system. Then reconsider the calls for the frequent booster recommendations. This is what researchers talk about as well. And they say this study may be useful for the healthcare authorities and physicians who are considering or asking for repeated boosters. And I added this one: look at the cumulative effect, because it's not just the COVID vaccine. I feel that there are other vaccines that are going to be mRNA based. And I am actually looking forward for the designer drugs for cancers that will be mRNA based. And again, the risk benefit is different over there. On one end, there is a possibility of death, and on the other end, there is a possibility of recovery. There is an mRNA-based vaccine drug design that was used, I believe, in Oregon, if I recall it correctly. And the patient who was refractory, their cancer actually completely went away. So mRNA technology has its need and its possibility potential. But if we continue to give it, what will be, imagine we have 10 types of medicines now based on the mRNA protocol. What will be the cumulative effect? I think we have to be very sharp and um, very calculated about that. I'm hoping that somewhere the healthcare authorities are saying to their teams, there is a team meeting happening somewhere where they're saying, hey guys, look at this study. This is what is possible. We already know that for a more serious outcome, 0.0035% is the possibility. Here is a study that is showing 2.8%. There is a Thailand study. There's an Israeli study. So if you collect the data, fill in the blanks, look at the whole spectrum, let's start watching for following things. Let's start making the guidances in this way. Guidances and protocols are formed all the time from these agencies, and they should do that here as well. Okay, so these are the side notes. Going back here, out of those 777 individuals, 40 participants developed cardiac um, troponin. Then they were adjudicated. Only 22 were um, didn't have any other reason for having cardiac issues, and they were supposed to be associated with the vaccine. And then 20 of them were women, 3.7%, and the range is really dangerous, 2.3 to 5.7%. And two men, 0.8%, and the range is 0.1 to 3%, the 95% confidence interval. Now, here is the testing. What they did was high sensitivity cardiac troponin is a newer test, and it is more sensitive. And so EKG or symptoms may not still be present, but this test can tell if there is a problem going on with the heart. So what they did was, first of all, they looked at the ranges present in the control cohorts. They saw what is so the troponin, high sensitivity troponin, is measured as nanograms per liter. So they measured there, and the number was 3 nanogram. They measured here, it was 5 nanogram. The individuals who received the vaccine, they had a higher level, especially those who had the injury. They went up, I believe, up to 17 nanogram per liter. Then they looked at their other markers. So here is what they did. Those who got vaccinated, out of them, those who didn't have any evidence of cardiac injury versus those that had troponin increased, they looked at other markers, and here is what they found. Systemic reactogenicity, that means fevers and chills after the vaccine, that happened in both groups. So that means immune system did become activated. So Paul says, excluding those with potential other reasons for positive result means that the results are a minimum, as one with prior heart involvement may well have been damaged by the vaccine and excluded. So what they had, maybe. So this is one of their limitation, that they were not able to do multiple days, number one, and number two, they didn't do a baseline as well. But still, they are actually pretty confident. I heard the talk from the researcher as well, Dr. Muller, and they did a very thorough adjudication to make sure that this is vaccine associated. Okay, so systemic reactogenicity is present in both groups. Then anti-interleukin 1 receptor antagonist antibodies were comparable in both groups. And why did they check this? And I have a diagram to discuss that. Why did they check this? Because they were saying that in the past studies, myocarditis, was thought to be because of this antibody. So they wanted to make sure that they measured this antibody, and they said that antibody was equal. So this was not the reason. Anti-NP was comparable to control. That means the patients were not acutely ill with SARS-CoV-2. Anti-S1 was comparable as well with the control. That means there was no acute infection. Systemic inflammatory markers, various interleukins and interferons, they were 14. They were all comparable except two. Interferon, I wrote gamma here. This is lambda. Interferon lambda and GM-CSF. These two were low. Now, let's look at these numbers. This is the third part of this talk where we're going to look at some of the mechanisms. First of all, let's look at the interleukin 1 receptor antagonist. And what does that mean? So imagine that somebody has inflammation. They got vaccine or got COVID or some other infection. This is the innate arm cells. That is the dendritic cells and macrophages and neutrophils and stuff. These cells are responding to alarmins. Alarmins are the sensors of the cell detecting something wrong. For example, toll-like receptor 4 on macrophage. Once the cell is alarmed that there is something wrong going on, the cell would start producing interleukin 1. That is just one. They produce a lot of interleukins, but they produce interleukin 1. Now, interleukin 1 is actually, interleukins 1 is a family of, I think, 9 proteins. Interleukin 1 alpha and 1 beta are two main classes. Here we are talking about interleukin 1 beta. Once the interleukin 1 is released, it is going to act on many kind of cells. I have put a list of some over here. For example, astrocytes in the brain, chondrocytes in the bone, endothelium in the blood vessels, fibroblasts in the connective tissues, keratinocytes on the skin, neurons in the brain, oocyte in the ovary, the eggs, the pancreatic beta cells, smooth cells, liver cells, and so on. Plus, here these blue ones are the T cells. So interleukin 1 acts on them. And of course, these cells, these little horns that I made here, these are interleukin 1 receptors. Good so far? That is interleukin 1. What happens is that when interleukin 1 acts on these cells through these receptors, then these cells become activated. For example, immune cells will become activated and inflammation will occur. So far, so good. There is some reason for the inflammation. There is a alarm that occurred, tissue damage occurred, virus occurred, appeared, or bacteria or fungus, something happened. Innate arm cell said, interleukin 1, there is a problem. They released it. Interleukin 1 went to various cells and activated those cells, which would then enhance the inflammation. Now, here is a funny thing. See this little troll face here? When the interleukin 1 is produced by the innate arm, there is also an interleukin 1 receptor antagonist protein that is produced too. This one is actually interleukin 1 like protein. It can bind with the same receptor as well, but it does not initiate the action of the receptor. It doesn't have the correct binding with the receptor, so receptor does not become activated. So it is kind of a troll. It is kind of a decoy. It looks like interleukin 1. It behaves like interleukin 1 for binding, but it does not trigger the action of interleukin 1. What happens is when our body wants to reduce inflammation, it has many regulatory mechanisms. One of the regulatory mechanism is to produce interleukin 1 receptor antagonist with this little troll protein that is going to go and occupy the interleukin 1 receptors that would not allow the interleukin 1 to act on them. And now these receptors are not going to trigger their cells, and the cells are not going to do inflammation. And so this is anti-inflammatory behavior. Now, in previous thoughts about myocarditis because of vaccine, it is thought that the body, as a result of COVID or vaccine, produces antibodies against interleukin 1 receptor antagonist protein, which causes this protein to reduce in amount, which opens up these receptors for interleukin 1 to act on them, which causes lots of inflammation. Does it make sense? So they said, we specifically looked for these antibodies to make sure that inflammation isn't occurring because these antibodies are stopping the interleukin 1 receptor antagonist that is opening up the receptor to interleukin 1, and that is causing more inflammation. Turned out there were no antibodies more than control. So they were comparable. So this was not a factor. So then what was the factor? Then they looked at another 14 inflammatory markers or mediators. There were 12 of them were all the same. Antibodies were the same. So they found these two. These two are, number one, interferon lambda. Just like interferon gamma is released by the adaptive arm, many other cells too, and it amplifies the innate arm. Interferon lambda's function is to reduce the inflammation. It is a regulator of inflammation. When interferon lambda is present, inflammation reduces, tissue damage reduces. Now, here is a delicate point. In these vaccinees who had a problem with their heart, in them, for some reason, interferon lambda was less in all of them. Why was it less? The researchers said, we do not know. How did vaccinees only, and the ones with the cardiac issue only had this one less? Was it already less and then vaccine was given and they were not able to handle the vaccine better? Or was it the vaccine that came and did something that caused the interferon lambda to reduce? They do not know. But there is an association of less interferon lambda in all of the cardiac injury vaccinees. So they thought that it is possible that we know that interferon lambda helps reduce inflammation. So if the interferon lambda itself is less, then its regulatory effect to reduce inflammation will be less. That would mean inflammation will be more, and that inflammation ends up causing cardiac damage as well. Sure, there will be other tissue damage too. So this is one curiosity on their end, and they said there should be more studies to figure out what is the role of this molecule. Then this was another curious change. Granulocyte monocyte colony stimulating factor is a molecule that goes from the inflammatory cells, innate immune cells or adaptive immune cells. It is released at the site of inflammation. It goes all the way to bone marrow and tells the stem cells in the bone marrow to make more cells. That is why it is called granulocyte monocyte colony stimulating factor. They stimulate the colony or the formation of these cells. Now, medicine researchers are kind of confused about GM-CSF. In COVID, there have been studies to give more GM-CSF to see if that helps the patient from severe COVID. And there have been studies that reduce the GM-CSF to see if that helps. GM-CSF in all of these patients was low as well. This is a pro-inflammatory molecule. This was low in everyone who had cardiac inflammation. Why was this low? They do not know. So this is another molecule that they said it is important to do some studies around this. They know that interferon lambda has been used for severe cases and patients, severe COVID cases. Patient of severe COVID, when given interferon lambda, their severity reduces. So there are studies for this. There aren't much studies for this one. And they said, we can't explain why this association was present, and there should be more studies. So then I'm just going to wrap up that number one, as I said before, these comparisons are actually not to be compared. They are actually to fill in the blanks for these spectrums of the problem. And here is a study that fills the blank here. There are previous studies that fill the blanks here. There are Thailand type studies that fill the blanks in this area. There need to be studies for the current variants. There are studies that fill the blank here for COVID previous variants. So this is really not a study to compare with others. And then I have already discussed why is it good for. Now, finally, if you like, if you have time, I can very quickly discuss how inflammation causes arrhythmias. It's a long topic. Would you like to discuss that, or should we just leave it here and stop? Don says, what are the children's heart issue studies? So there are two studies that are interesting. One is the Thailand study, and the other one is Seattle Children's Hospital study, which I have presented both of them, where they saw the cardiac issues that developed after vaccine for even up to 5 months. Okay, so folks are saying, KoolBeens are saying that let's discuss it. So let's do a very quick review of how inflammation can cause arrhythmia and heart failure. So I'm going to make an abstract of the cardiac chambers. So let's say these are two atria separated from each other, and then there are holes in these atria that connect them to the chambers below, which are ventricles. Now, between the atria and ventricle, there is a connective tissue pad which is non-conducting. It doesn't allow electrical activity to pass from atria to ventricle or from ventricle to atria. This is an insulation layer between atria and ventricles. So now let me make ventricles here as well. So again, this diagram is only to understand the electrical activity and structural activity, and not for hemodynamics or the blood dynamics. These chambers below are ventricles: ventricle, atria, atria. Between them is this insulation layer that makes sure that atrial activity doesn't go to the ventricle and ventricle activity doesn't go to the atria. Now what happens is, we know that over here in the right atrium, near the opening of the superior vena cava, is an electrical node or collection of neuron-like tissue, which is actually specialized cardiac muscle tissue called SA node, sinoatrial node. And on the Dr. Bean, I have discussed this in detail. There are 110 videos of cardiovascular system only, because I love the cardiovascular system. And the link is in the description to just get access to all of them for 67. Okay, so here, SA node is present. Down here, near there is a small triangular area near this node. We have AV node, or atrioventricular node. What happens is, there are three bundles of electrical wires, which are really specialized muscle wires. So whenever I say electrical wire now, just consider a specialized muscle of the heart wire. There is one that goes here like this, one that goes here like this, and the one that goes here like this. So these are three wires connecting these two nodes. Then there is a specialized wire inside this connective tissue, which then divides into two branches in the interventricular septum. Interventricular septum is the division between the two ventricles. Right? Now, when there is cardiac inflammation, Imagine if there is inflammation. Inflammation simply means there is a problem, there is an injury somewhere. If that injury occurs right at the SA node, imagine SA node or the tissue around that is inflamed. That would destabilize the SA node. It can go down in its activity or it can become accelerated because the electrical channels, the ionic channels can become disrupted. So these specialized tissue cells, they have sodium channels, they have calcium channels, they have potassium channels, and these channels are um, leaky channels and they work to create automaticity. If you create inflammation near these channels themselves can become faulty and they can start firing incorrectly, which will make the wire to fire incorrectly, which can cause arrhythmia. And this is true for the whole electrical part of it. Now, this is also possible that we get re-entry. Re-entry. What is re-entry? What happens is I'm going to make a few cardiac muscle cells. Imagine this is one muscle cell, this is another muscle cell, this is another muscle cell, and one more muscle cell. Four of them. We send the electrical activity to them at the same time. So what happens is all of these four will contract together because they receive the activity together. This is called syncytium or unit. They all contract together. Imagine you making a fist with all of your fingers closing together. When they're all contracted together, these red cardiac muscle cells, then the electrical activity doesn't matter if it spills from one to the next one. Actually, it cannot spill because they're all already in the electrical activity. And so they are what we say in a refractory state. However, think about it for a second now. Imagine that this one fiber or this group of fibers is inflamed and it is either responding to the electrical message faster or slower. Let's make it slow for a second. Imagine that this fiber is now responding slow. That means electrical activity went down the other pathways very fast, but is really going slowly here. Now, by the time this activity reaches the end, other activities have actually happened and gone. So this one is still going while other fibers have contracted and relaxed already. So the syncytium, the unit is broken and arrhythmia is going to develop. So now what happens is that when this activity reaches here, from here, because the other cells are now relaxed, they are ready to receive another message, this activity spills in them. This is called re-entry. And all of a sudden, instead of listening to the SA node or AV node to depolarize, these cells are now depolarizing through this cell. When they get depolarized, once again, the activity would go and re-enter here. And when they re-enter, these guys would have contracted and relaxed, and this another impulse is just going and it would re-enter here. And all of a sudden, we have an arrhythmia. This is a rough explanation of what re-entry is. Re-entry can happen because of the problem with the electrical activity. It can be because of inflammation of the heart. It can be because of the size change of the heart. Some fibers are longer abnormally in failing heart and some are shorter or some are normal. And so the longer fibers are taking longer time for the cardiac activity, which causes re-entry and so on. Then the inflammation can cause ionic imbalances. Inflammation can cause calcium entry in the inflamed tissue, which can then cause irritation of the channels there and the surrounding tissue. Inflammation can cause scar tissue formation, which can irritate the other cardiac tissue around it. All of that can lead to arrhythmias. And if this happens again and again, then the cardiac failure can occur. So the this I actually agree with this mandates and hospital workers. This is a study from employees. They were on the receiving end of it. It was one, they were needed to help with COVID. There was a ethical need for them to be there. They had to be the heroes to be there. And then the mandates meant they had to be whatever it was. At that time it was not known that vaccines are going to do this. Whatever it is, they had to be exposed to it. Then mandates caused a threat to people's financial well-being. So anyways, this is the discussion. I know it is 1 hour long, so I don't think anybody is going to watch it. But anyways, this is my review of the study. Stay safe, happy, and healthy. Like, subscribe, and share. There is a link in the description for this weekend once again for access to Dr. Bean with a one-time, really tiny amount of fee. And with that, nice weekend. I'll see you on Monday. Actually, not Monday, but next week. Bye for now.